All right, well, thank you everybody for joining us on this kind of dreary, rainy day. Hopefully your internet won't be too negatively affected. But the good news is we are recording this, so if you do drop off and you miss some information, we'll be sharing the recording as well as the slides and resources after the presentation concludes. Probably going to need about 3 or 4 days, so probably midweek next week we'll get everything out to you once the video is produced. Thank you to Charlotte from Baltimore City Health Department, Tanya Parker, and Dr. Seward from Planned Parenthood of Maryland for bringing a lot of this really great information about telehealth and how you can prepare to provide services in your family planning clinic during this COVID-19 pandemic. So I'm going to send it over to Charlotte in just a moment. I would like everybody to just become a little familiar with the functionality of Zoom. If you wiggle your mouse, you're going to see a pop-up at the bottom, and you'll have lots of options. And one of them is the chat. First thing I'd like for everybody to do is chat us your name. And the reason I'm asking for that is just to verify you are attending, and so that we can make sure that you get your certificate of attendance. Okay? So please, first name and last name.
Oh, this is super fun. I'm seeing everybody's name pop up.
Mm-hmm.
Demetria Rogers, Baltimore City Health Department. Can you hear me?
We can. We can.
Okay.
So we are going to ask everyone to go ahead and mute their microphones. We're going to use the chat also to interact and ask questions as we go along. All right, the next function I'd like for you all to find are the reactions. So you can do applause, you can do thumbs up, basically just saying that you like something that you heard. And then the final one is polls. We're going to be providing polls during the session. I'll control those, so when that pops up, please participate. You'll have about 20 seconds, and then we'll make sure that we share the results of each of those polls. Okay? Looks like everybody is doing great with the chat. All right, so if everybody is good, we are going to pass it over to Charlotte.
Good morning, everyone. It's awesome to see so many familiar names and some faces. Thank you so much again for being here with us and being really flexible with sort of the changing landscape that's happening right now, particularly in family planning, as we're finding ways to work together, collaborate, learn from each other, and really provide ongoing essential reproductive and sexual health services to our clients and our communities. So again, I appreciate everyone's flexibility and just being open to new ideas. So what brings us here today, obviously, is our ongoing global pandemic, and looking at this as, while we recognize this is like hard times personally, professionally, with challenges, that this is also an amazing opportunity for us to innovate and adapt to really meet our clients and communities' needs, utilizing some technology that we have readily available. So what we're going to do today is go through, hold on one second, I'm sorry, my computer is not transitioning slides. There we go. So we have the honor of having with us both Tanya Parker and Avi Seward from Planned Parenthood of Maryland to talk to us about the initiation of their telehealth practices, and then also share some lessons learned that they have that we can then apply back into our clinics. And then after that, we're going to get into more of the application of COVID preparedness within our clinics. So looking at ways we can really support, not only keeping our staff healthy and safe, but when we are able to provide those essential services in person to clients, whether in the clinic or even if we're working to do curbside initiatives, like what are ways we can keep both ourselves and our clients, safe and healthy. So most of this information is either coming from Planned Parenthood of Maryland, or it's been adapted from a bunch of different resources. We, part of our family planning team has been on a ton of webinars and connecting to all different sorts of resources and toolkits and support guides that are out there. So what we're trying to do is just adapt a lot of that content, hit the highlights, share it with you, and then from there share additional resources. So I want to share with you really quickly these two quotes from the World Health Organization that really just again uplift how critical and essential our work is with contraceptive services, family planning support, and acknowledging that sexual and reproductive health doesn't stop during a global pandemic. If anything, there's even more of our clients and the services and support they need that will fall through the cracks because of the pandemic. So we're trying to look at ways that we can innovate so we can keep serving our communities. And on that, I want to initiate our first poll. Deb? So I'm curious, to the best of your ability to answer this, how are family planning services currently being provided within your clinics? So whether that's in person, such as business as usual, same old protocols, are you limiting your in-person appointments? You know, particularly if it's just mostly at risk, most need? Have you switched over to just telehealth or some sort of combination of all of these? And you can select all that apply. Give me another quick second to do that. All right, let's close the poll and see what you guys say. All right, so it looks like a almost even split. So telehealth initiatives are definitely happening at least halfway or across, you know, around a little over 50% of our clinics, as well as we're still providing in-person appointments. So this will be really interesting to see, you know, talking about what Planned Parenthood of Maryland is doing and looking at ways that you can apply some of their practices over to your work. Awesome. So with that, and the slide may turn in a minute, I want to turn this now over to Tanya and Avi to talk about their work with Planned Parenthood.
Thank you so much, Charlotte, and thanks so much for including us in this presentation. It's really nice to be with you all today. So we are going to talk about the telehealth project that we launched here at Planned Parenthood of Maryland just recently. I thought I'd first start off by just walking through the timeline of how Planned Parenthood of Maryland responded to the pandemic up to where we are at the current moment. So almost 2 months ago now, it's hard to believe, we convened a COVID-19 response task force made up of senior leadership, operational and medical leadership, and representatives from our health centers to really drive our response and develop new policies and procedures that we knew would need to come. So this group started meeting in early March, and we've been meeting daily ever since. One of the first processes this group worked on developing was how we start screening patients for symptoms of exposure. And if any were reported, then we would reschedule patients for 14 days later. That was at the beginning of all this. And so we started that process on March 9th. By March 17th, our patient volume was decreasing. Our staff was starting to be affected by school and daycare closures. So we made the decision to consolidate our hours and eliminate evening and Saturday hours. We also limited the type of services we were providing and scheduled patients further out if they were coming in for preventive visits. Then on March 23rd, with the Secretary of Health's order to cease all elective and non-urgent medical procedures, we reduced our services even further to a very limited range of urgent-only services that at this point include infections, STI treatment, problems with LARC methods, ELA or an IUC for emergency contraception, pregnancy testing with problems, and abortion services. So in response to being able to only provide these urgent services at our health centers, we had started to ramp up our planning to offer other services through telehealth. And on March 27th, we trained all of the health center staff who would be involved in providing telehealth, and we launched it that very day. The first few days of providing telehealth coincided with the governor's stay-at-home directive and telehealth regulations expanding as well in early April. And beginning April 4th, we were allowed to start offering asynchronous.
Yeah, this now smells great.
It sounds like there's some background noise, so if you can mute yourself.
Yeah, Tanya, I'm going to go ahead through the participant list to make sure everybody's on mute for right now.
Joanna, but I can't hear it.
Okay, so we are utilizing 2 different telehealth platforms, and Deborah, it looks like maybe you're...
Okay, I'm moving it onto the other screen. I apologize.
Oh, no problem. Let me go back to the first slide. Okay, we're utilizing 2 different telehealth platforms. These have both been developed nationwide for by Planned Parenthood affiliates across the country. The first one is PP Direct, and that's a platform for asynchronous visits for birth control and UTI treatment. And in the month of April, we've seen over 370 visits this way. And then we also use a platform called In Touch, and that's for synchronous video telehealth visits. And through that platform, we've seen, as of last week, we saw over 270 patients that way. The way that PP Direct works is it's actually an app that you request birth control, either a pillow, patch, or ring, that is scripted out or mailed to patients. We also can provide UTI treatment if we meet a specific criteria, and that's scripted out as well. Consents are built into the app, and because this is asynchronous, meaning it's not live, patients can access this 24/7. So this platform for us is that it's not a way to bill insurance for the visit. So this app only is able to be used by patients who are willing to pay for the visit, although they can use insurance to pick up their prescription at a pharmacy.
No.
So because of the increased demand for services this way, we've expanded the hours that our clinicians are staffing to be able to meet our patient demand. And there's still some background noise. Identify where that's from.
Hi, folks. If you could go ahead and please mute your mics. I think we hear a child in the background, which...
It sounds very cute.
Yes, absolutely. Thank you so much.
Thanks, Deb. So the second platform we're using for telehealth, and the one that we're going to really focus on today, is a platform called In Touch. It's a synchronous live platform. And we've actually been using this platform exclusively for the last few years to provide medication abortion services through telehealth. But now we've expanded it to include family planning services. Using this telehealth platform is allowing us to bill insurance and Medicaid. We also see patients who are uninsured and fall under Title X guidelines this way, and they pay on a sliding fee scale. So how this works is patients schedule an appointment through our call center or online at our website. We send them a link to the visit through text. The visit is conducted through the telehealth platform, and we're providing these services at this point during our business hours, Monday through Friday. So at this point, we have another poll to launch. Before I launch into more about how we're doing telehealth, we wanted to find out more from you all about the services that you're providing through telehealth. So Deb, we're going to launch the next poll. So we're asking at this point, are you currently implementing telehealth? Yes, you're doing it now, not yet, but starting to offer telehealth and have protocols, or not yet, you're exploring, or it's not an option for you at this time. So why don't we go ahead and close that poll? Wow, 75% of our participants are already providing telehealth. That's fantastic. All right, so I'm going to share the types of services that we're providing here at Planned Parenthood of Maryland through telehealth. So we're providing contraceptive care, birth control, start and prescription changes. And recently we added the ability to prescribe depot and have patients self-inject. We do the training through the video, and then we either send the prescription to the pharmacy or we can mail it to the patient. We had just launched gender affirming care prior to the pandemic. And so we're using telehealth as a way to be able to continue to offer that service both to patients who already started with us, doing follow-up visits, and also to initiate care with us. We're doing emergency contraception through telehealth, STI treatment for patients if they have a known diagnosis of or exposure of chlamydia and trich, resupply visits, refills for antiviral meds, UTI treatment if they don't have symptoms of fever or pelvic pain, and we developed a screening questionnaire that our call center staff uses to identify if a patient's eligible to be scheduled for a telehealth visit this way. We can initiate PrEP and PEP, and we send patients to LabCorp for the lab work for that visit. Vaginitis infections, STI testing and HIV testing, again, we send patients to LabCorp for the lab testing, so we are not doing any lab testing at our centers for patients who are being seen through telehealth. And we are doing care coordination. And at this time, we're not offering LARCs at our health centers or obviously through telehealth. That would be challenging. So a couple of requirements for, in order to provide telehealth. The patient has to have a device or laptop with a camera, although we can provide the visit over the phone if needed, if the patient doesn't have access to a smartphone. We ask that the patient agree to have any lab work done at LabCorp, and that's easy to find on the LabCorp website for a service center near them. And if they also agree that we will either script out medication or mail it to them if the patient is self-pay. We did recently start offering limited curbside pickup of medications, and I'm going to talk about that in a little bit. And then we also are requiring that patients live in Maryland to receive telehealth services. So this is just an overview of the workflow for telehealth, just to give you the sense that it does require multiple steps, and in our case, we are utilizing multiple staff in our health centers to be part of the visit and provide services to patients. We're going to walk through this in a little bit more detail. So the first stop is the call center, unless the appointment is made online. But most of the time our patients are calling our call center to schedule an appointment, and the call center will screen them for eligibility for a telehealth visit. They'll then schedule the appointment on a telehealth appointment slot, and we use NextGen practice management and EHR system, and we have designated appointment schedules and designated time slots for telehealth. And at that point, patients are directed to our patient website to review consent forms ahead of time. They're also informed that they will receive a text link that they'll click on for the visit, and they should be prepared to answer a call from our main number prior to the visit. After they've made the appointment, then the front office staff at the health center where the appointment's been made will verify insurance eligibility, and then at least 15 minutes prior to the visit, they will call the patient to perform check-in and registration over the phone. So at that point, they collect any copayment by credit card. If the patient is self-pay and qualifies for Title X, we ask for family size and income, and we're asking for self-reported family size and income. At this time, we're not asking for any sort of documentation on that. And then the front desk staff will tell the patient to click on the link that will be sent to them before their appointment time. And that link is only available to be clicked on 15 minutes before the actual time of the appointment. And that staff person will also remind the patient, if you haven't already, please go review our consent forms on the website. And because this InTouch platform does not integrate with NextGen, the front office staff does need to then log into the InTouch platform. They create a patient account, schedule the visit, and send the patient the link by text. So at this point, I'm going to turn things over to Avi, who is a nurse practitioner who works at our Owings Mills Health Center, to share how the provider part of the workflow and the visit goes.
Hello, everyone. Thanks for joining us today. So I'm just going to speak to the clinical portion of a telehealth visit. So at this point, after the patient has been logged in and registered, the medical assistant in the back office will log in on a separate laptop. And they usually go to a room and ask the patient to also be in a safe, secure place where they can ensure privacy, especially if they need to discuss anything that is private in nature and confidential. The MA will get verbal consent at that time. The InTouch platform does not allow for consents to be in the platform, so we do get verbal consent and we do document that. You can advance. So as Tanya was saying, we do document in NextGen. So there is a checkbox where we can verify that we're doing telehealth, and that will also help with billing. And then we go through their entire history at that point, discussing whatever the need is, the reason for their visit. So they are their allergies, everything is gone over just like it would be if it was an in-person visit. The only thing that is not done, nothing hands-on, is we don't do vital signs. And after all of that history taking, we still do all of the social history, all of the sexual health questions. We still do all of that via video conference or over the phone. They will place the patient into a waiting room or on hold, and then they will notify me that the patient is ready to be seen. At that point, I usually log into the NextGen platform and just review what they're coming for, if they're a new patient or an established patient, just go over why they are visiting us today. And then I just simply hit the connect button in the InTouch platform, and that connects us via video conference. And I still introduce myself very similar, again, to if you were to have an in-person visit. And I also ask them to verify their identity just to make sure that I'm speaking with the correct person. We go over the reason for their visit, their chief complaint, any concerns that they may have. And then after that interview portion has completed, we will either, if it's like an STI visit, then we send them to LabCorp in order to have their testing completed. They will leave their samples there. They can have their blood drawn there. If it's testing and treatment, then we can send their treatment directly to a pharmacy. Same with birth control. The only thing that's different with our birth control visits is that we do not require that they have their vital signs taken, of course, in office. We just ask that they have their vital signs or their blood pressure taken within the last 12 months. And as long as that has been normal, we can provide them with birth control for a year's supply. Our self-pay patients, we can either mail it to them or we can arrange for a curbside pickup. At the end of the visit is when I complete the billing with the code and usually a modifier to signify a telehealth visit. A couple of things that are very helpful. is to have 2 computers or 2 screens so that you can flip-flop back and forth between the video conferencing platform and your documentation. It is sometimes difficult to document at the same time while you are on the phone or on the video conference with the patient. And then sometimes patients have connectivity issues. The call gets dropped. I've had people who are very confidential, so sometimes they're outside, sometimes they're other places, and while that's very private, it doesn't leave for a very good signal. And so therefore, it's sometimes we lose dropped connections, and we then have to send another link. If necessary, if all else fails, you can complete the visit over the phone. And then also, like, depending on what type of phone they have, if they have an iPhone or an Android, sometimes there's connectivity issues. But one thing is you may sometimes have to ask them to disconnect their Wi-Fi.
All right, thank you, Avi.
You're welcome.
So before we move on to talking about patient access to medications and supplies, we had another poll to just find out from you all how you are ensuring that patients do still have access to medications. So here's the poll that asks, what is the main way you're getting birth control and medications to patients? All right, shall we close the poll? And it looks like many of you are also doing curbside pickup and mail, but most are sending to the pharmacy. Great, so we are doing all of those options as well, and want to make sure that our patients still have access to the medications and supplies that they need. So we're extending refills for non-urgent visits. So if a patient's not able to complete a telehealth visit, we provide 3-month extension on refills. We try to mail prescription refills as much as we can, but we recognize that there are patients who are not going to be able to get medications by mail. And so we created a policy to offer curbside pickup. And I thought I'd just review how that process works. So we have a pretty strict criteria for patients who are eligible to pick up medication from a health center, just to reduce the amount of patient contact. So a patient cannot be sick, so we do screen them for symptoms. They cannot have medications or supplies mailed to them due to some sort of confidentiality reason, or maybe there's unsecure mail delivery where they are. We can allow patients to pick up if they're using NuvaRing as birth control, because we don't mail that. Patients are eligible if they need urgent medications like UTI treatment that really shouldn't wait to be mailed, or if they need a prescription for partner-delivered therapy and can't have them mailed for confidentiality reasons. We also wanted to be able to offer patients the ability to still pick up condoms or Plan B over the counter. And so they are able to do this as long as they coordinate ahead of time with the health center. So most often a patient will call the the call center regarding the need to pick up medications. And so our call center staff will identify which health center is most convenient for the patient to pick up. Let the patient know that a staff member will call them to arrange the pickup, and then they'll send a task through our EHR system to that health center. We'll then have a health center staff person, once they receive that task, call the patient to make sure they're eligible to pick up medications in person, identify how many supplies and what the cost would be, advise the patient to have the payment ready, if applicable, and we're strongly encouraging credit card payment. If the patient does need to pay in cash, we let them know we're not going to be able to make change. So either they can give us the change as a donation, or we can put it on their account as a credit. We let the patient know about the hours for the health center where they're coming to pick up, and give them the phone number of the front desk extension. So let them know that they should call us when they arrive, but if they can't get a hold of anyone, they should come to the front door. And we also ask who's going to be picking up the medication, because sometimes it's not the patient, but it's someone else in their place who is coming to pick it up for them. So once the patient arrives, they give us a call. We take the credit card payment over the phone, collect information on the description of the car and the location if the person is in one of our health centers where there is a parking lot. At some of our locations, like in Baltimore, the patient may be standing outside the health center. And so the health center staff will then get the medication that we've pre-packaged and go outside with appropriate PPE on. We ask the staff to wear a mask, keep at least arm's distance from the patient, and really try to minimize conversation just to expedite the pickup. Again, if they're paying cash, we're not providing change at this point. And then when the patient comes back, they returns, they perform hand hygiene and finish up that curbside pickup. So that is what we had to share today on how we're offering telehealth, how we're offering curbside pickup, and just in terms of the lessons that we've learned from telehealth. It I think was a little bit surprising to us that some patients actually don't show for their telehealth visits. So we still have a no-show rate. Either we can't get in touch with the patient for the original registration, or sometimes we have done the registration over the phone and the patient still doesn't show up for their actual appointment. We have found that it does require quite a bit of education to have patients understand what a telehealth visit is. We've had some patients actually show up at the health centers for their telehealth appointment. We've had other patients not be in a confidential setting, and so it's been challenging to talk to them, and sometimes the visit needs to be rescheduled. And then technology challenges have existed from day one, and so just planning for that to happen and planning for a backup plan that we call the patient over the phone if we can't finish the visit through telehealth was important for us to do from the get-go. So at this point, I'm going to turn things back to Charlotte.
Thank you so much, Tanya and Avi, for all of your insights and guidance. This is incredibly helpful, as everyone, again, right now, if you have not initiated telehealth prior to COVID, are probably, starting new and writing new protocols and setting new screening standards and trying to guide their staff on best practices. So we really appreciate, y'all's insights. So thank you. So what we're going to do now is I'm going to kind of go through preparing our clinics as we look at ways to serve our patients during the time of COVID. Some of this information might seem self-explanatory, but I just really want to re-emphasize it so that way you feel like we have sort of like a baseline of common knowledge of like best practice for clinical care, and trying to like conceptualize ways we can support and keep our staff safe and healthy as we are also trying to keep our clients safe and healthy. All right.
And I think I gave up my remote access. So Deb, you may need to give it to Charlotte.
There we go. So as you probably know by now, since we've now been in this for almost 2 months, of some primary symptoms that are associated with COVID-19, I just wanted to share this slide again, and also to answer a question that I know had popped up in the chat. All materials, including the slide deck, but we also have some additional reference and resource materials, will be shared after this presentation. So that way, you don't have to, I guess, write down every single word. We will make sure we get this content to you. So with this, I wanted to just really re-emphasize some of the primary symptoms so that way we can kind of keep it in our mind as we are navigating how are our staff doing and keeping an eye on primary symptoms that they might be exhibiting, and for us to set protocols to take the best measure of, does it make sense if they have a dry cough or fatigue, or and I know it's a little bit tricky right now because we are in allergy season, but I think using due diligence and a lot of caution is probably one of our best ways to prevent the spread. So whether it's, again, keeping our clients safe or keeping our staff safe. So a lot of the information that's being disseminated right now is coming primarily from the CDC as they try to think through what could general practice look like when we open the doors of our clinic. Seeing that a lot of you, around over 60%, are doing telehealth practices, there's a chance that it might just be your providers and your staff who are coming into the office. Even though some of you might also be providing limited in-person visits as well. So again, these rules and regulations should be applied to both of those scenarios. This is not just something that we want to implement caution only when patients come in, but we have to also consider the well-being of our staff and of our providers. So one thing that the CDC keeps reemphasizing, Governor Hogan set a statewide mandate over, is that we have to wear masks when we are in public. So this means when you step outside of the front door of your house, apartment, wherever, you have to be wearing a mask. And so this does in fact apply back over to our clinical settings, even if we are just doing telehealth practice. Obviously, if you do a telehealth practice and you want to remove your mask for that, that's fine, but using the precautions necessary to ensure that the space is clean, that your monitors are clean, things you are touching, you're not touching your face, and just really re-emphasizing the importance of that when there are two or more people in a space, like, we do need to be wearing masks. It's a way to ensure that if we are asymptomatic, meaning we might have the virus and not even know it, that we are not transmitting it to others and others are not receiving that. So also conceptualizing our waiting rooms, trying to think about ways that if we are having clients come in, what are ways that we can space out their waiting space, making sure that all of our patients, when they come in, are wearing a mask. So ensuring that you have enough PPE on hand, or there are so many websites out there on ways that you can do no-sew mask options, whether you're using t-shirts or bandanas. So this is some criteria you can give to clients before they even come into the clinic, as well as your staff, to ensure that there's no transmission. As I said, wipe down surfaces, use hand sanitizer. This isn't new information. We most likely have already been given this information just via best health practice and what we hear on the news. But this does need to apply, again, to even more emphasis within our clinics. And whenever possible, some best practices have been shown to actually just have your patients wait in the car. So instead of having them sit in the waiting room until they need to be seen, have them wait just right outside your clinic in their car, and you can either text or call them when it's time for them to be seen. And as the practices in hospitals right now and in other public spaces, no visitors. Obviously, if you need to navigate that with your patient, if there are certain exceptions, maybe it's a parent and child, or possibly a family member that has to translate if you don't have translation services. Obviously, you can take that a case by case, but in general, we're trying to have no unnecessary amount of persons within the clinic than needs to be. And that also applies to our exam rooms. So this practice that I'm sharing right here is coming very specifically from the COVID-19 clinical care recommendations out of the CDC. Obviously, as with everything we say, you have to take this as a clinic by clinic, protocol by protocol basis. So you need to figure out what is going to work best for you depending on the staff availability. But one of the big things that they keep re-emphasizing for all of our essential healthcare workers and anybody going out in public is that if you are showing any sort of symptoms, that you need to self-quarantine for 14 days, limiting your access. And I know this is hard because our work is so critical and we are in fact providing essential services to our clients, but this is, unfortunately, we are navigating a new virus. And so this is probably one of the best ways that we can do to prevent transmission and help keep, again, both our staff and our clients safe and healthy, is to just monitor symptoms and making protocols around, all right, if you start showing symptoms or possibly have been exposed, this is what our practice is going to be. And I reemphasize this again. It's really critical that you and your staff and administrators, your clinic as a whole, come up with a protocol that's going to work for you. And again, trying to utilize CDC best practice, and you have it on paper, and that you make sure you take the time to go through it and answer questions with staff. I think it's best to have a uniform approach that everybody is working off of instead of sort of piecemealing it as the situation comes up. There's a lot of questions and concerns, and we just want to keep everybody in the loop, making sure information is transparent and everybody feels supported. So one practice that I heard that was kind of came up in a previous webinar was appointing a trusted COVID team leader. So is there a staff or an administrator that could be maybe a main point person that's able to check in with our staff and see how are you doing? At Baltimore City Health Department, within our family planning clinics, one of our administrators has actually been sending out a weekly newsletter with both supports and resources and ways to sort of check in with our staff. And this is great because we can not only talk about best practice for keeping ourselves and our families healthy and safe, but we also talk about things like self-care and ways that we can manage, this is very anxiety-inducing, stress-inducing, and, mad props to our staff out there that are also serving as homeschoolers right now. Like I do not have a child. I cannot imagine the stress of trying to work a job function while also navigating childcare and schooling for your child at home. So we want to make sure that we are being always cognizant of where our staff are coming from and really checking in with them for emotional and as well as physical well-being, as well as asking your medical and non-medical staff to take your temperature daily. So this applies not only to our clinics coming into our clients coming into our clinics, but also checking with our staff, making sure that they have access to a thermometer and that they are managing their temperature daily. So that way, if they might be asymptomatic outside of all of a sudden noticing a fever, they don't need to come into work. And really, again, reinforcing your PPE policies of wearing masks at all times, coming up with a routine or schedule around cleaning your clinic and exam room. So you're going to need to have a strategy that is most likely more frequent than what you were doing prior to this. So that most likely looks like a turnaround of cleaning the exam room after every client visit. Again, cleaning your keyboards, cleaning your monitors, any of the systems that you are using for your telehealth practices, cleaning pens that maybe people are using for sign-in, making hand sanitizer available, trying to think through strategy like that. As well as, I thought that this was great, depending on what your protocols are. If a staff member comes up sick, some suggestion that another organization had given was sharing, if you're able, your sick or PTO days with your colleagues. It's just looking at a way of communal support. Obviously, this is case by case and you figure out the discretion that works for you. I just thought it was a really interesting approach to kind of support each other at this time. This is re-emphasizing a lot of what Tanya and Avi were already referring to as to understanding the sort of the screening that needs to happen up front with, can this be a virtual or in-person appointment? And then also, if we are doing in-person, really conceptualizing what does that in-person visit even need to look like. So for example, some best practice that has been brought up before was that, are you able to do your pre-visit and collect medical history over the phone prior to them even coming into the clinic? Again, we're trying to limit the amount of time that we are in these spaces together in order to prevent transmission and exposure, as well as the follow-up counseling, the plan for best medical practice coming out of that visit, and prescriptions and refills. Is this something that can actually be done over the phone after the visit? I know, again, we are adding all these additional steps to our visits, but again, the idea is what are the best way we can keep both ourselves as these providers of services as well as our clients safe. As with sort of the best practice for our staff in terms of taking your temperature and monitoring symptoms, we would definitely re-emphasize making sure your clients do that as well. So maybe before they're coming in, having the clients call on the day before or the day of and do a quick check around. All right, I need you to take your temperature. What is your temperature? Are you exhibiting any of these symptoms currently? And do they think that they've been exposed to COVID? This is a way of sort of making a screening decision decision if this is appropriate for them to come in now, or should we try to reschedule the visit for 2 weeks. And also, as Avi and Tanya have mentioned, that there are ways that we can shift some of our contraceptive access and our access points to no contact. So we will have some resources we're going to share with you on best practice around depot sub-Q self-administration for our established patients. Again, that's considered best practice. As well as our drive-through STI services. Some clinics are able to provide it, some may not. It's probably best if you really highlight what services are being provided so that way your staff can let your clients know. As we mentioned, possible curbside pickups or even mailing for accessing contraception. And then I want to share a great resource that we have with our partners out of Johns Hopkins, which is the iwantthe.kit.org. So what it is a by mail contraceptive or STI testing kits. And so the contraceptive piece, oh, that's just referring to mailing in general. I apologize. The I Want the Kit resource relates specifically to STI and HIV testing. So it is they are able to input their name and address, answer a few questions right online, and then a kit will be sent to their house. They can do the swabs and send it back to get their testing completed. And if they are a Baltimore City resident, they can actually do HIV testing as well. And then also, let's innovate. Let's think of ways that we can be doing referrals and connecting with other clinics. So if your clinics are providing limited services, is there another clinic nearby that wouldn't be burdensome to also refer a client over for additional support and care? And I know that this could relate to potentially LARC insertion or removal. Some clinics may provide it, some may not. So let's look at ways we can collaborate and refer. I'm going to touch very quickly on the telehealth coding, claims, billing piece. I'm touching on it very quickly because I want the information to be here within the slides, as well as we will build out on this within the resource guide we will share out afterwards, but just as a way that you have exposure to this information and know that this information is around to help support you. So it's important to understand that telehealth is actually how the service is being provided. It's not the service itself. And most commercial payers are really following the Medicare guidelines right now in this emergency to switch over to telehealth. There's also Title X regulations, which, fortunately we're under the Maryland Family Planning program, but we are supported and protected under those regulations. All Medicare beneficiaries are covered for these family planning services via telehealth, regardless of geographic location or originating site. They could be a brand new patient. There is no referral needed, no establishment needed. Also, HIPAA has modified regulations that you can actually do telehealth practice, as Avi and Tanya were mentioning, using things like FaceTime and Skype and everyday communication technologies. There are now 2 new definitions for encounters that we can utilize within our coding for our visits. And one is a virtual check-in, which this is a patient-initiated communication with the clinician. So it's for an established patient. So this means that maybe they're reaching out over telephone or video to decide whether an office visit or service is needed. So this might play into some of that screening piece that needs to happen with the provider and the patient. And then a digital e-visit is what's associated with a non-face-to-face patient-initiated communication through our online portal. So if they're sending a message to our doctors or our physicians or our clinicians, we can count that as a digital e-visit. It's really critical, as with everything that deals with coding and billing, that we document, and we document clearly and consistently and effectively. And so as we switch over to more telehealth practices, making sure that we are documenting this. We're talking about the mode of telecommunication that's used, where's the location of the patient, as well as the provider, and making note of any other participating staff that might be involved in the visit. And we need to document consent. I'm going to talk a little bit about this right here, is that I think Avi mentioned it as well as some general practice around how you document consent within your EMRs, but it's really critical that we are obtaining verbal consent and documenting this verbal consent within our medical records. If possible, it's great to share that consent documentation or language with our clients. It's also recommended that you can obtain like written consent once the client's able to come back within the clinic. And here's an example of some documentation language that can be used in medical records. So again, these slides will be shared afterwards. And lastly, I want to make sure that we acknowledge, as some of you have seen in articles in the news, is that there has been a real rise of intimate partner violence with these shelter-in-place regulations. So how do we apply that with our confidential services that we're providing now via telehealth? So when you're initiating your telehealth visit, it's always important to sort of scan the room and introduce yourself, and then offer up, is there, who else is in the room, or who am I talking to now? I would say recommend coming up with your own little spiel that you use at the intro of a telehealth visit as a way to sort of initiate to see if there's anybody else in the space. This also applies to our adolescents or our minors. We know that there's a lot of challenges right now with being able to connect with them to provide our sexual and reproductive health services via telehealth, especially to maintain confidentiality. So there's a way that utilizing these practices, you could also do screening with them. And something else that's been recommended is sort of in your initial spiel and sort of introduction of this telehealth service, saying if at any point you would like to stop discussing this topic, change the topic, or stop it in general, feel free to do a gesture. So like, put your hand up or use a certain word. And it's a way to sort of that you can stop it, acknowledging that there might be something occurring within the space that they do not want to be overheard. And also consider intake forms that patients can complete privately. So these are what I consider probably, if you looked at nothing else, what I consider some of the top links to resources that apply specifically to Maryland as well as family planning. So our Maryland Department of Health has put up an amazing website that goes over sort of COVID-related resources. Johns Hopkins University is maintaining one of the main databases that's keeping track of COVID illness, and the CDC actually has guidelines very specifically for clinical health services and best practice within clinics for both our providers and providing services to clients. So I really recommend kind of doing a glance through those recommendations. Our partner, the National Family Planning and Reproductive Health Association, that does nationwide support to family planning clinics, has a publicly accessible COVID resource page. I really, really strongly recommend looking through this, particularly as it relates to questions you might have around billing and coding, for example. They have wonderful toolkits and support resources specifically for family planning clinics. And lastly, Essential Health Access Health has been offering now 2 different COVID preparedness trainings as it applies to family planning services. So I have a link right here to the 2 different slide decks for it. The second one actually includes case studies for if you're looking at what does contraceptive counseling look like via telehealth and some best practice, and then also how to navigate like sub-Q depot conversations with your clients. And very, very lastly, we have taken a lot of the main highlighted information in Avi and Tanya's materials, as well as my own, in addition to the litany of right now resources that exist on supportive measures for clinical practice during COVID, and tried to hit some of the main key points within this document that we will be sending out to you guys. It's called, there's the title for it. And within it is also some additional links to other resources if you would like to go further, and you are always more than welcome to reach out to me, and I can see if I can link you to any other resources. And that is pretty much it. Yeah. So again, everybody just, please stay safe. I highly recommend, again, coming up with written protocols that way is best practice for your staff to know what to do. And then also having conversations among your staff about ways that you guys can support each other and keep each other safe and healthy. And I do notice we've had a handful of really excellent questions come up within the chat. And I think for the sake of time and trying to be respectful of the time that we've allocated for this, What our team might do is look through and pull those questions. And then when we send out the slides and the resource document, we'll try to give you a quick little blurb answer if possible related to these questions. So again, we can be mindful of your time.
Great, thank you, Charlotte. Thank you, everybody. So just a couple things to bring us to a close. We want to put, out into the world more information for you all, and we are really kind of sad that the Reproductive Health Roundtable was canceled. And so Charlotte, Rachel, Merrick, and myself, and the team from the Department of Health are working together to put together a series that's going to be from June until August. So stay tuned for more information, because we thought we really wanted to make sure you still had an opportunity to get some learning. If you joined us a little bit late, please make sure you add your name to the chat box so that we can make sure you get your certificate of attendance for today. And just a list of the things that we will be sending afterwards. We're going to send you a link to an evaluation, and we really do value what you have to share. So please, please, please offer your feedback so we can continually improve. Like Charlotte said, we'll be sending resources and the slides. And we're going to take the questions out of the chat and create a frequently asked questions document for you all. But I have to say thank you, Tanya and Avi, for answering questions along the way. That was really, really helpful. And then the recording, the link to the recording. So thank you very much for the support of the State of Maryland Department of Health, Baltimore City Health Department, Planned Parenthood of Maryland, and Healthy Teen Network. Be well, everybody. Stay safe.
Bye, everyone.